This is our technique for open knotless fixation of a lateral femoral condyle osteochondral fracture fragment, as is often seen in the setting of lateral patellofemoral dislocation. Here are our disclosures. Diagnostic arthroscopy, seen here, revealed an osteochondral fracture defect, as well as an osteochondral fracture loose body, which was removed arthroscopically. Attention was then turned to an open procedure via lateral parapatellar arthrotomy to identify the fragment. Curette was utilized to prepare the bed of the defect to best accommodate the fractured articular fragment. Once there is a healthy bleeding base of bone, a 1.6 millimeter K-wire is utilized to create vascular channels to assist with healing and ingrowth. The osteochondral fracture fragment is trimmed on the back table and trial reduction is performed. Preparation is then made for a 2.5 millimeter push lock anchor. 2 ovicral sutures in differing colors are loaded into the anchor, and the pilot hill is drilled, and the anchor is seated at the medial apex of the fracture defect. The anchor is seated and then removed with excellent fixation. Next, the fracture fragment is brought to the field and reduced within the bed of the defect. A bioabsorbable trimmet pin is then utilized to provisionally fixate the osteochondral fracture fragment in preparation for final knotless fixation. Here we see the pin being pre-drilled and inserted and then trimmed with an electrocautery type device. The pin is then countersunk below the level of the articular cartilage. Next, preparation is then made for 2 lateral row knotless anchors. A pilot hole is drilled, and 1 of each of the colored sutures is retrieved and loaded into an additional 2.5 millimeter push lock anchor, which is seated just off the lateral articular margin of the femoral cartilage. This is then repeated at the apex laterally of the defect to create a double row type knotless fixation construct in a triangular configuration. Here the final anchor is being seated with excellent reduction and fixation of the fractured fragment. Suture tails are then trimmed. Fibrin glue can be utilized around the perimeter of the defect as needed. Here we see the fracture fragment is stable to range of motion with excellent reduction. Additional fibrin glue is then applied. The arthrotomy is then closed, and we proceed with MPFL reconstruction to stabilize the dislocation. Here is the physical therapy protocol, which will be followed the osteochondral fragment fixation and MPFL reconstruction. Thank you for your interest in our technique.